But Jason, what about extracranially? I mean, this urban legend that you could give a brief burst of BRAF/MEK, light up the tumor, and then give immunotherapy. Do you do that in practice?
I would say I rarely do that in practice currently. I think that that's actually an open question. I think great data that was generated now seems like a long time ago, but really not too long ago, to show that there is actually, after initiation of BRAF inhibitor and presumably with the combination, you do see an initial influx of CD8 T cells into tumors. And that was mostly from data in cutaneous lesions, although some deeper lesions, suggesting that you could then amplify an immune response. Now, I think that that's a fraught area because the interrogation of those infiltrating TIL are not exactly well characterized to know whether that's truly making the tumor inflamed in the broad sense of gamma interferon associated gene expression, but it does suggest that you could have a benefit. I think that's actually a separate question, though, around this idea of using the therapies in an optimal sequenced way for an individual patient. So if we think that we could reduce the LDH, we can bring down the disease burden, and then give the patient an opportunity to get the most benefit by another therapy, that's using it in a slightly different manner, and I think both questions are probably important, but are not necessarily overlapping.
Okay. So let's segue for just one moment. We haven't talked about toxicity. We've danced around the issue of the fact that our therapies can be very effective, but again, at what cost? So Mike, how do you talk to the patients and how do you monitor them for side effects when you're giving immunotherapies, for example?
I think that, that conversation really starts with trying to explain to patients about how immunotherapy is different from, patients come in thinking about chemotherapy. And so the fact that the mechanism is so different, the way it works is so different, but it also means that the side effects are so different. I certainly, again, talk with the patients extensively about how important it is to communicate to physicians when they do have side effects. Because again, I think the experience that we're all building up is that as long as we actually are able to hear about the side effects relatively early, that our interventions are very successful at getting those under control. The patients where we've had extreme difficulty are patients who actually don't report the side effects that they're having, and they present when the side effects are extremely advanced and can be really quite refractory to treatment at that time. So I think that the key for us is really sort of emphasizing that communication, particularly with the data that patients who've had autoimmune toxicities from immunotherapy are often patients who actually, in terms of the anti-tumor effect, are having a very good response. And actually holding therapy or using immunosuppressive treatments to control the side effects doesn't seem to abrogate that anti-tumor effect. And so trying to reassure patients, because there's often a lot of fear, they don't want doctors to stop their treatment, to really reinforce that, no, this is really a case where the dangerous thing is for us not to know about the side effects that you're having.
Yes, no question. Okay, so last topic in this section is, we have the world's expert on intralesional therapy here. So Robert, have you routinely been using TVEC, the injectable engineered herpes virus, alone, or do you think it should ultimately be used with a checkpoint inhibitor?
I think it's a very good question, Jeff. So I think that in patients with earlier disease, these are patients with in-transit and lymph node metastases, such as the 3B and 3C patients, and also some patients with distant lymph node and cutaneous lesions, the stage 4 M1A patients. There, I think TVEC by itself can actually be very effective, and we know that the response rate in those patients, the global overall response rate in that patient population is 52%. So actually it's a very high percentage of response. Now what we haven't known is that in those patients specifically, what's the response rate to the checkpoint inhibitors? So for instance, the ipilimumab we presented at ASCO yesterday, the results of the 264 study, which was ipilimumab versus TVEC plus ipilimumab in a phase 2 randomized clinical trial in patients with unresectable stage 3B, 3C, and stage 4 melanoma. And looking specifically then at that patient population, these earlier patients, the 3B, 3C, and stage 4 M1A, the response rate to ipilimumab in that patient population, it was 19%. So I think that it's clear that in this patient population, the injectable therapies seem to be more effective than that. Now, we don't usually use the ipilimumab as the first-line therapy for these patients, and we use PD-1 inhibitors more often. But we also know from data there that the response rate to the PD-1 inhibitors in that patient population is in the order of about 27 to 35%. So, to answer your question, Jeff, I think that in these patients with earlier disease, patients that have a limited amount of disease, I think that using an intralesional therapy such as TVEC is very appropriate, and we can get durable responses In addition, we have also presented data that shows that in these patients that have not yet developed lung and liver and other distant metastases, there is some patients that actually will have a increased time to developing those. So TVEC seems to potentially prevent those patients from developing it. Having said that, though, in patients with more advanced disease, patients that have lung and liver and other disease, I do think that these oncolytic immunotherapies should be used in combination, which the 264 study also showed yesterday, that in those patients it definitely is more beneficial to use these in combination. We also now have ongoing studies as well looking at this specifically with PD-1 inhibitors. There's a 265 study in which we are randomizing patients to receive intralesional TVEC plus pembrolizumab versus an intralesional placebo, which I think is very important, because the whole question is, what does that intralesional therapy really do? Or is it, can we just inject something into the lesion and get the same immune response? And we don't know the answer to that. So in that control arm, we have intralesional saline that we're injecting with pembrolizumab. And I think that study also will tell us, we hope definitively then, that combining these two therapies, the intralesional therapies and the PD-1 inhibitors, if that is more beneficial than the pembrolizumab by itself.
Okay, and we'll get back to TVEC in just a little while, because you're talking about it used up front.